Hi everyone, my name is Jacqui and I am going to be talking today about including a relationship focus in early childhood interventions. We have had a lot of interest in this webinar and 55 people registered for the event, which is fantastic. I'm guessing that some people might log on as I'm talking a bit as we go, and also this link is going to be available afterwards, so there are also people who will be not live in the webinar. So welcome to people who are here live today. Today I'm going to be talking about some context around current early intervention practices at the moment in Australia. I'm going to be talking about definitions of including a relationship focus, some of the evidence that informs this way of working, briefly touch on how to get started with families, so the language we use to introduce a relationship focus, and share a couple of tools that we've found really valuable here at MAMRAE. And then a little bit of time on if this webinar has really resonated for you, where to from here, and at the end there'll be about 15 minutes for questions as well. So just to let you know, as you come into the Zoom, you are all muted, and if you can leave your questions until the end, and you'll just need to remember to unmute yourself if you're wanting to talk. Okay. So a little bit about me before we get started. I'm trained as an occupational therapist and I've been providing clinical services to children and families for about 17 years now. Mostly children under the age of 6 with moderate to severe developmental difficulties. And I'm currently working at MAMRAE in Brisbane. And we provide an early childhood intervention service that uses a relationship-based approach. I've also recently completed my PhD in the area of how allied health practitioners can include a relationship focus as part of the work that we do. And I provide Play Connections training, which used to be called Play Connect, and that was a one-day training, and I've changed that to a 2-day training called Play Connections. So if we think about early intervention as it currently stands, the research literature is indicating that it's still very common for therapists to conduct activities directly with the child themselves to support child development and participation in everyday activities. So our aim is a really nice one. We're trying to maximise the child's participation in activities that are important for them developmentally. A recent study by Peterson in 2018 indicated that, from memory, about 70% of clinician time is still spent interacting with the child themselves. And it's a very small percentage of therapy sessions that is spent where the therapist supports the parent to interact with the child themselves. That was a study conducted in America. There's another study that was done in Australia, but that was 2009, so a number of years ago now. And the findings of that study were similar. That was by Rogers and colleagues, and that indicated that most of therapists' time is spent interacting with the child directly ourselves as clinicians. Why it's important to think about this is because the effectiveness of a more developmentally orientated early intervention, where the therapist is the one interacting with the child and then providing strategies to the parent, has been questioned in the literature. And a systematic review conducted by Case Smith and her colleagues in 2013, the findings of that systematic review was that developmental theory in isolation is not enough to have an effect on a child's developmental outcomes. In addition, it's been suggested that the effectiveness, I'll just move my video. It's been suggested that the effectiveness of early childhood intervention is not related to the amount or intensity of the service received, but the ability of the parent to read their child's cues and respond sensitively. So this was a study done by Corralson in 2011, and Mahoney has done similar studies where they said that whether or not the intervention directly targets parent sensitivity and responsiveness, if there are increases in how sensitively attuned the parent is as a result of the intervention, then that intervention is going to be much more effective than those interventions where parent responsiveness and sensitivity did not change. So I think this is a really interesting and quite powerful finding in these studies, because often parents ask us for more therapy to have an effect for their children. And this is, I guess, I feel quite important to share with parents that sometimes it's not all about more therapy is better. And if we are working with parents to read their child's cues and respond to those moment to moment, that can actually have a much more powerful effect on the child's developmental outcomes. So in the last, well, for a number of years now, there started to be this call in the literature for practitioners to include a relationship focus as a core component of the intervention we provide. And I'm going to talk a little bit about how I've done that with services that I've worked with in a phased way. So by that I mean we start with more of a focus on parent-child interactions, and then once those interactions are more attuned and resilient, then start to add in our developmental guidance. Commonly, just on that point, when a relationship focus has been included, the literature is suggesting that it may not be a core component of the therapy we provide. And that's certainly like that study by Peterson in 2018, that while therapists may be including some time in sessions for parent-child interactions, it's not considered to be the core of what we do. So there are a range of interventions that include a relationship focus, and some of you have probably done training in them. They include DIR floor time, the Hannon workshops, Circle of Security, the Denver model, and Watch, Wait, Wonder. And what is common amongst some of those interventions is that there's a focus on promoting positive parent-child interactions that we know are associated with optimal development for children. And secondly, that the parent-child interactions and the parent being sensitive and attuned to the child's cues is to meet the unique needs of that particular child. So rather than kind of scripted interactions. So here we have this concept of the importance of, and I've mentioned this on the previous slide, collaborative and attuned patterns of interaction between the infant, young child, and the parent. What I found from my experience of doing a number of these trainings was that it made sense to me in theory, but I was a bit stuck in what I do in a session. How do I introduce this way of working with parents, especially when parents may have an expectation that I'm going to be doing the majority of the interacting or the work with their child? And how do I structure a session? How do I set the room up for a parent-child interaction session? And I didn't really have, after attending that training, the confidence to run, I guess, or facilitate relationship-based sessions or include a relationship focus in the work that I was doing. And certainly in the interactions I've had with a number of therapists over the last 5 years or so, that seems to be a common difficulty in implementing a relationship focus, is how do we communicate this with parents, and how do I build my confidence to work in this way? So when we're thinking about a definition of including a relationship focus, there's not yet an agreement in the literature about what a common definition is. But like I said on the previous slide, there are some common themes that come through. So this definition that I've included is one from Stuart, who's an OT, and I like it because it's quite simple and makes sense to me. So when we include a relationship focus as part of the work we do, parents are encouraged to tune in to what their child is doing or how they're behaving and respond sensitively to those particular cues. And that is happening moment to moment. So the parent then needs to adapt the response to meet the child's changing needs over time. So as a child starts to make developmental gains, the responses from the parent are going to change to meet that increase in development as well. Interestingly, I did a study asking, as part of the training that I do, and I asked therapists what they thought the definition of working relationally was, and it was very common that therapists thought it was that they connected with the child in an attuned and collaborative way, and that as a therapist they tuned in to what the child was doing and behaving. So I think there is some confusion around what is a relationship approach, and that's fine, because everyone works differently and there are advantages and disadvantages of every approach that we have. But I think it's just important to highlight that when we're talking about, I guess, the importance of relationship-based approaches for optimal development, that here we're talking about parent-child interactions, and that the parent is key in the therapy session rather than the therapist. So the other crucial element there is that the parent-therapist relationship is considered to be a vital component of the effectiveness of working relationally. And there's this term therapeutic alliance, which is used in the literature, and that without a strong therapeutic alliance, it's very hard to include a relationship focus. And I'm going to talk a little bit more about that later on in the webinar. The other key part of working relationally is that waiting to see what the child signals or initiates is often the first step. And it's a very important first step in this way of working. And I can speak from experience and also from the interactions I've had with a number of therapists that waiting is very difficult for both therapists and parents to do. Especially now that we are charging for sessions under the NDIS, therapists can feel like perhaps we're not doing enough when we start with waiting. But the importance of the child actively signaling for their development, and I had one therapist say, actually, less is more. So by waiting and supporting a parent to wait, we are actually providing a really rich therapy service. So why do we encourage waiting and child-led play as some of our first steps, including a relationship focus? Waiting is considered to be a really important building block for more complex skill development. So when we wait to see what a child signals with their body or their communication or in play, it helps the child practice their skills. And the more that they initiate and get a response for that, they're likely to initiate again. And so they start to, through repetition and practice, achieve skill mastery. In the mastery motivation work, there's this idea that for children to master skills, they need to feel pleasure and they need to persist. And so when we wait and the child shows us a signal, they get a lovely response from mum or dad that feels good, they get that sense of that pleasure, and they want to do it again. I'm going to persist with something that is a bit more tricky for me. And for children with developmental delays, where their body doesn't perhaps move in the way that we would hope, or it's harder for them to learn skills, they actually often need more opportunities for persisting and for repetition. So this is where waiting can be even more helpful for those little ones where development is tricky. So another consideration is that when a child has a developmental delay, there are a lot of associated emotions that go on for the parent and family. The impact of stress, grief over the potential diagnosis, worry or anxiety really affects our well, for all of us, our ability to tune in to what's happening moment to moment, because we often get caught up in our heads around our stress and our emotion. So it's often harder for the parents that we work with to be sensitive and responsive because of the worry or the stress that they may be experiencing. In addition, what the literature is suggesting is that when a parent is worried about their child's development, they'll often become, and then the literature it's referred to as more intrusive in their interactions because they're so wanting their child to develop well. And intuitively, parents will often work harder with their child. So when the parent is doing more for the child, there are fewer opportunities often for the child to initiate or show their signals. And with the children that we work with developmental delays, they actually need more practice. So we're wanting to increase the opportunities that they have for giving us signals and for initiating. So you can start to see here, there's this kind of double whammy effect happening where the parent, in wanting to do the best for their child and as a result of being worried, may wait less and do more for their child, and that's actually unfortunately not helpful for the little ones that we work with. In addition to that, we have children where it can be harder to engage with them, it can be harder to read their signals, or it takes much longer for their child to show a signal or to respond to the parent's response. So this means that parents are often required to learn how to consciously wait. And if waiting can be hard anyway, and then we're asking parents to do more of that, we need to be really mindful that this is a new skill often that they're needing to learn. And it's in the context of this child's kind of unique skills and differences as well. So they may not need to wait so much for their other children, and it's not going to have as much of an impact. But for this little one who needs more opportunities to initiate and where it takes longer for them to initiate, you're going to need to wait more. If we think about what informs this way of working, there is a huge body of evidence now that advocates the importance of the parent-child relationship. There used to be a debate, nature versus nurture, and we seem to have reached an agreement in the literature that it's nature via nurture. So we really understand a lot better now the interactive influences of genetics, the environment, and those early experiences that the child has and how that has an influence on brain architecture. In the 2-day Play Connections training that I run, I actually spend about half a day on the evidence that informs this way of working. And for the purpose of a 1-hour webinar, I'm just going to touch on it very briefly. I'm very happy to send reference lists for people who are interested in looking at the research in more depth themselves. Or if you'd like to come to the training, that's another way of getting a summary of the research literature at the moment. So in addition to neuroscience, which has really helped us understand, I guess, what happens when parents and children are interacting in attuned and collaborative ways. So through wiring little ones' brains up, we've been able to see that when a child initiates and the parent responds, their brain is really lit up, versus when an adult has the idea and kind of does something to the child or for the child, it's much less of the child's brain that is lit up. So that's why this kind of waiting to see what the child initiates and following child-led play ideas is considered to be really important for facilitating optimal development. The brain is really lit up and lots of wiring is occurring. Other models and theories that support the importance of self-initiated play and the parent-child relationship are the dynamic systems approach to motor development, the transactional model of development, mastery motivation, and attachment theory. and you may be familiar with some of those, but clinicians often report that it's really helpful to know that there are these theories that really back up this way of working, and that it doesn't all come from attachment theory, that there's other theories that are supportive of this. I thought I'd share an interesting study that is quite specific to the area of ASD, a systematic review that was conducted in 2013, these researchers looked at 17 studies of parent-mediated interventions for children with autism, and they found that the most effective interventions were the ones that focused on parent interaction coaching, where there was an increase in this kind of attuned and collaborative patterns of interaction between the parent and the child. So what that means is that the child made the most gains developmentally where the interventions focus on parent-child interactions. So quite compelling, and that it's a Cochrane review is quite exciting as well. From an OT perspective, and for those of you who are early childhood therapists that are thinking about play and supporting child play, when we think about the occupations or the ways that children are learning in early childhood, most of the things that young children do occur in the context of a significant adult in their life. So when a child is learning to eat independently as an infant or young child, there will generally be an adult at the table with them. When a child is learning to walk, a parent or caregiver is generally alongside them, or the child is walking towards the parent or the caregiver. When the child is learning to get dressed, the parent initially is the one helping lift it. They've got the shorts and they're encouraging their child to lift the leg and put it in. So here you can see that some very specific developmental goals that parents might have for a young child usually require an interaction with an adult. So if those interactions aren't smooth and collaborative, and it's difficult to see what the child is signaling or initiating, it's really hard for there to be a smooth flow with those developmental tasks. So if a child has the sense that when I show an initiation, mum or dad don't see that, they get frustrated or they give up, it's going to be much harder to teach dressing, for example. Or if meal times are constantly a source of stress because again, the child's signals aren't clear, or the parent isn't able to respond to those in a way that's sensitive and attuned, then meal times take on a flavour of being quite stressful times in the day. And that's just one reason why, but it's an important one to keep in mind. Also, this concept of relational connectedness. So when a child is playing, and even those moments where you think, oh, they're totally occupied, I'm just going to step away for a moment and quickly stir the dinner, the child will often straight away tune into the fact that mum or dad has left the room. So you may not have been doing anything other than being a presence in the room and watching over the child, but as soon as the caregiver is absent, the child doesn't want to persist with that activity anymore. And one of the reasons for that is because sharing an activity alongside someone or with someone often creates more meaning for the child and can really help with their participation. Also, if the child gets stuck with something, they know they have their caregiver close by to help them with that persistence, or kind of the scaffolding to achieve the next step in the activity. So the quality of these relationships can really impact on the child's developing sense of self, their self-worth and their quality of life. So for those little ones where they have the experience of, I've got good play ideas, or I've got good signals to give, mum or dad see them, oh, that feels good. And the way that brain development is at this stage of kind of under 4-year-olds being very egotistical, children have this concept of I make good things happen and I make bad things happen. So when I do something that mum or dad delight in, I did that. I've got good ideas. I'm a good person. So you can see with lots of repeated experiences of my play signals and my initiations are seen, that can really help build that child's sense of self. And when they go then into the childcare or preschool environment, they've got this sense of, I've got good ideas to share with other people, versus the little one where signals are much less salient, happen less frequently, or are harder to read. They're getting this sense of, my signals aren't seen, they're not responded to, and perhaps I give up because they're not responded to. Or I get really frustrated because my needs aren't seen or met. And for children with developmental delays who we know are more at risk of becoming passive as they get older, that kind of learned helplessness, this is a really important consideration. So in summary, what the research is telling us is that children with developmental delays have a much higher risk of a disruption to the parent-child relationship. And there was a study done a number of years ago where they looked at children with neurodevelopmental diagnoses, and what they found was that these children had an incidence of about, it was very high, about 30% with disorganized attachment relationship. In the general population, it's less than, I think about 5 to 10% have a disorganized attachment relationship. So that is a significant difference. And some of the thinking around why that has occurred is that this idea that what the child is bringing to the relationship, it's often harder to give clear signals. And then in terms of what might be going on for the parent, it's much harder to be attuned and responsive when we're feeling distress ourselves. So when parents are experiencing grief and loss or additional demands with parenting because of the nature of the child's delays, it's harder for them to tune in. Coupled with a child where it can be harder for them to initiate things and give us clear signals. Why this is important is because there's a strong agreement in the literature that when children have more secure attachment relationships, they have more optimal developmental outcomes. So this is, I guess, indicating that the children that we work with often have more risk to the parent-child relationship. We already know they have risk to their development, and perhaps the risks to the parent-child relationship are adding further risk to their development. So if we're thinking about the work that we do, it's indicating that parents may need more support with waiting and reading their child's cues because of the nature of the child's delays, and that when we're able to do this, this can actually make our interventions much more effective. I'd just like to highlight here that when we include a relationship focus, I'm not talking about throwing out our other developmental information and knowledge that we have to share. And there's huge value in that. But what I've found in my practice is that when we start with a focus on parent-child interactions and then I build in my developmental guidance, that's a often way more effective way of working than when I kind of come in as a first step with developmental strategies. So if we're including a relationship focus, it often requires a shift in our practice. And certainly the way that I was trained and that I was initially practicing as a therapist, this line at the bottom of this triangle between the therapist and the child was a solid line. So most of the work that I was doing in a session, I was doing directly with the child myself, and then I would give the parent some strategies at the end or home program. So then the line between the therapist and the parent was, I guess, the broken line, and also the parent and the child. Not as much focus on either of those things. When we include a relationship focus, we're changing the focus here. So most of the work that I do is with the parent, for the purpose of the parent then having the skills or more ability to tune into their child and to respond sensitively moment to moment and adapting responses to meet the child's needs. And there's a paper, it's not a hugely robust study, but and I can forward this article on with some of the, with the email at the end of this presentation, that for every hour that a therapist spends directly with a child, that equates to an hour of benefit for the child. But for every hour that a therapist spends with a parent, that equates to 84 hours of benefit for the child. So that is quite an astounding difference, and again adds weight to the importance and the value of us really working alongside parents in sessions. And the reason why we've got this dashed line on the bottom for the therapist and the child is that there are times where we still do interact directly ourselves with the child, and there's value in that. So when we're doing assessments, for example, if you decided that there was value in modeling or coaching, that's when there might be times that you're interacting with the child yourself. I would say here, though, that if you do make that decision to model, do it with caution and clinical reasoning, because there is literature that suggests that when we model a certain way of interacting with a child to the parent, it can actually decrease the parent's sense of competency, and that when parents have a decreased sense of competency, that can actually reduce the quality of parent-child interactions. So yeah, if you're feeling like it's clinically indicated that that would be valuable, I feel as long as we're making those decisions consciously that this is a moment where this would be helpful, then that makes sense. So what is our role then in the session? If we're going to be sitting back a bit more and facilitating parent-child interactions, what do we do in the session? And here, when in the 2-day training, I go into that a lot more, especially with the use of video and how to structure a session, how to talk about what a session is going to look like with a family, and how to introduce that right from the beginning. So what is a parent expecting when they walk through the door? How is that different or similar to what you may offer? And the importance of that right from the start. And the reason for that, there's the need for informed consent, but also because the therapist-parent relationship is such a crucial component to working relationally. And in a lot of the literature, they talk about for the parent to be interacting with the child in smooth and collaborative and attuned ways, there's often the role for the therapist to do that with the parent, so that the parent has an experience of what that feels like, what that looks like, and then if they don't have their own roadmap of that, it can become easier to give that to their child as well. So the therapist needs to be able to create a space in the therapy session that contains the parent's concerns. So when the parent is feeling very anxious about the child's development, anxiety is very contagious emotion, and it's very hard as a therapist not to get hooked into wanting to do more and I guess fix what's going on for the parent and the child. So often what we're doing in these first sessions is setting up a space where the child is able to initiate. So the parent's able to wait long enough, and the parent is supported to read that very unique signal and respond to it. The therapist also needs to be able to communicate that the parent is doing a good enough job with their child. So we're not aiming for perfect parent-child interactions here. And there are going to be lots of moments that interactions aren't attuned and collaborative. And in the literature, it talks about that 30% of the time of being sensitive and responsive is enough to help support a secure attachment relationship that supports optimal development. And here what we're really aiming to do is strengthen what the parent's already doing. So what are their unique ways of their child, and how can we build on that in a way that helps their child? Also, our role is to assist the parent in observing their child's signals and problem-solving possible responses. And this is about reflective function or reflective capacity. So a parent really is required to get into the shoes of their child and think, what might they be trying to communicate right now, or what do they need from me right now? Much harder to do that when a parent is feeling distress or worried. So this holding environment that we're offering as therapists is a space to start practicing that. And when a parent has that practice and then is able to do more and more of that, that becomes easier. So for the parent, they have the experience of their goals being respected, that they still have control in the therapy process, that their parenting strengths are being built upon, and that their unique styles of parenting or of parent-child interaction are valued and supported. So we're not saying you do it this way, or that this is the only way to interact in a positive way. And the literature has indicated that when we use video with families, so we video a parent and a child interacting and we watch that back with the parent, that makes our interventions much more effective. And when we do use video, what we're effectively doing is helping to slow moments down. So we can watch an interaction back a couple of times and really wonder, what does that particular signal mean for your child, and how could you respond in that moment? So here you're problem solving with the parent together, and often asking the parent first, what do you notice and what do you think might be going on? So here you can see a lovely alignment between including a relationship focus and family-centered practice. And it's been suggested that including a relationship focus is like the next level of family-centeredness, that by understanding the impact of parent-child interactions and what might be getting in the way of that, we're actually working in an even more family-centered way. Because if we, give a home program without understanding what can feel difficult in the interactions, or what a child may be, how they might be responding, it can make doing a home program really difficult, and then can affect parents' sense of competency, which is important. So just before we move on, the use of video, while it's shown to be more effective, is often quite daunting for therapists. And certainly over the number of years that I've supervised therapists, this has been something that they've often found the hardest to implement in their practice. So in the 2-day training that I do, we spend a lot of time talking about how to structure video review, whose equipment or what equipment to use, how to actually do the review with the parent, and kind of some helpful performers around that as well. So the other thing that's commonly reported is that how we introduce the importance of a relationship focus, or why that might be helpful to reach developmental goals, is really hard. And having the confidence of the language seems to be really important for clinicians. So I've got a tool here that I'm going to share with you today that I use and that clinicians have reported has been really helpful. And the second tool I'm going to share with you is something I use in initial appointments to help parents reflect on the power of waiting for their child. So this is a language pyramid that's been adapted from the DIR floor time developmental levels. And here, if a parent came in with the goal, I want my child to talk, and the child has delays that mean there are lots of other things that need to happen first, and in your observations you feel that a parent-child interaction approach or including a relationship focus would be really helpful, then could you bring this tool into a first session and say, I you know, your goal is to support your little one with their expressive language development or their talking. And there are a number of steps to getting to talking. And one of those really important foundation steps is that your child needs to give you signals and initiate things that we can then see and respond to. When we do that, that is very organizing for your child. Mum sees that I'm starting to get a bit excited and I need some help calming down. Oh, mum sees that I like movement and I want more of that. So this kind of the trust that is developed through the child having the experience of my signals are seen and responded to is very regulating. And then when a child is calm alert, that's their best state for playing and interacting. When we are playing and interacting and the parent is naming what the child's doing, putting words into the language bank, that is helping develop receptive language skills. And then the more times a child hears words, the more likely they are to start using them, depending on what's going on from a developmental perspective. So here I would say to a parent, for your goal of talking, as a first step for the first couple of sessions, we're going to focus on waiting to see what your child signals and how to best respond to that. And from there, we're going to build in other things to get to talking. But this is a really important first step. This is another tool that we use, our parent and child playtime tool. I just talk this through rather than giving it as a handout in their first appointment, and we're very happy to share this with you at the end of the webinar, and also the language pyramid that I just talked about. So in an initial appointment, I'd take the case history, and then towards the end of the session I might say, it's really helpful for us to see how your child plays and how your child gives you initiations and signals, and how that's all kind of going. So can you play with your little one for about 3 minutes and just play as you'd normally play? Then at the end of that 3 minutes, I say to them, okay, so this time I'd like you to play with your child for another 3 minutes, but wait to see what your child does. So that's going to involve following your child's play ideas, and if you want, you can put words to that or you can imitate it, but the key thing I want you to do in this 3 minutes is wait. After they've done playtime 1 and playtime 2, some reflections. What did you notice was similar or different between the first play and the second play? And often parents will say, wow, my child did a lot more. In that second play, when I waited, they were way more engaged. They did a lot more than they usually do with toys or activities or with me. And it can be really surprising for parents that this kind of doing less actually is really worth a lot more for their child. And generally parents will reflect on, in that first play, I was actually really quite involved in leading what was going on, and my child didn't do as much. When a parent gives you those sorts of reflections, it's then really easy to segue into, and this is why focusing on parent-child interactions as a first step can be really helpful in optimizing your child's development. And so for the first few sessions, we're going to focus on waiting to see what your child initiates. The value in using a tool like this is that you're not needing to, I guess, sell the approach to the parent, because they're making those reflections themselves. And I'm continually surprised at how insightful parents are with this very simple exercise of play 1 and play 2. So we have developed this as a handout as well, and there's just a bit more information about why waiting can be helpful, and why this is a useful reflective activity, and you'll get this in the email as well. So in summary, before we have the opportunity for some questions, child development for young children occurs in the context of the parent-child relationship. And we know now that these patterns of interaction that occur between a parent and a child from birth are really key to how a child's brain is wiring. Optimal learning occurs in the context of relationships where the child feels emotionally supported and valued. And for children who have experienced perhaps medical trauma or who have a developmental delay that makes it much harder for them to give their signals, this is a really important consideration. So when we're including a relationship focus as the first phase of the therapy, the parent-child relationship becomes the focus of the intervention and also the method through which the intervention is delivered, with this real emphasis on reciprocal interactions. Just to close, in terms of the Australian context, in 2016, Early Childhood Australia released the national guidelines for best practice in early childhood intervention. And in that document, it is recommended that early childhood therapists do support parents with reading and responding to their child's unique signals and strengthening parent-child relationships. In addition, the NDIS had a working group that looked at the do's and don'ts of early intervention, and they call that document the 7 key principles. And principle 1 references the need for learning to be relationship-based. So there's often this question of, well, what about the fact that we now work in the NDIS? And so I think it's important to know that the need for services to be relationship-based is being advocated in our context in Australia. Additionally, there was a study done in 2018 where the researchers interviewed allied health practitioners about their work and the inclusion of relationship-based approaches or the parent-child attachment. And the findings of this study were that early intervention therapists perceived the parent-child relationship as an important consideration in their work, but less than half of them actually felt comfortable targeting parent-child interactions in their intervention. And one of the recommendations from this study was that we really need to support allied health practitioners to build their knowledge, skills, and confidence in this area. In the study that I did, I had more than 130 allied health practitioners attend the one-day training that I did at that time, and I did a 3 to 6 month follow-up and asked practitioners, what did you notice was different when you included a relationship focus? And some of the things that therapists said were that children were more willing to try new things with the support of their parents, or that the children had increased persistence with more challenging tasks. Children were making gains more quickly, or making more gains when actively participating with their parents, and that they noticed increased participation and child development over a number of areas. So really great findings in that study. Interestingly, they also said that children were happier overall and that they noticed a reduction in difficult behaviours such as hitting, screaming, and headbanging. For the parents, some of the observations were that families appeared to be less dependent on the therapist and feeling more in control and better able to manage situations themselves. Parents were demonstrating more initiative and problem solving at home. Increased parental awareness and understanding of the impacts that they can have on their child's engagement and performance. And I really like this. They observed more warmth and affection between the parent and the child, and the sense of relief that it's okay to enjoy their child. And then again, this reduced levels of stress and anxiety for both the parent and the child. So in summary, we do need to consider that we often were trained with very developmental models, and that this requires us to shift the way that we're working in some way. And that triangle, I think, summarizes that quite nicely, the shift that has to occur with us working more solidly with the parent who then works with the child. How working relationally fits within the our work role, and how we can start to take small steps to include a relationship focus in our work, holding both the parent-child relationship and child development together as we work with families. If you are interested in understanding some of the practice implications in more detail and having the opportunity to role play some of the tools and have more time with the evidence that informs this way of working, the next Play Connections training is on the 11th and 12th of November, and you can register for that through the MEMRE website, which is the same one that you registered for this webinar. And I'm going to pause here for questions and comments. So just remember to unmute yourself before you start to talk. Okay. Or you can also go into the chat function if you prefer, if you don't have a microphone on your computer. I'm just going to pull up the chat function so I know how to do this. So I'll stop sharing my screen and then Zoom will come up fully. Okay. So does anyone have any questions or comments? Always a bit awkward on a webinar, isn't it? Oh, I've got a message come up. Here we go. So this is a really good question. How can we apply this approach to non-ASD clients? And I would like to highlight here that my PhD included a focus on children with cerebral palsy. So I was certainly looking at, is this way of working effective for children with other diagnoses, including children with much more specific motor needs? And yes, we can certainly apply this way of working to children with a range of diagnoses. And in my last clinical position in Darwin, we were working with children with a range of difficulties. I guess in the field of autism, there's been more research that's been conducted, and there are some more specific approaches like DAR floor time that have a real lens for children with that particular diagnosis. Clinically, what I found was that, and again, I go through a case study in a lot of detail in that 2-day training of a little girl with cerebral palsy who was so frustrated with the body not doing what she wanted it to do that she'd have given up giving motor initiations, and she was not playing or interacting as actively as her mum or her dad would have liked. And when we started with a relationship focus, this little girl made quite outstanding gains in 5 sessions. And there's on the MEMRE website, there's a summary of children, of 3 children. One of those little ones has autism and the other 2 don't. So you can get an idea of, I guess, a clinical story with children with 2 other diagnoses. But yeah, I think to go into it in this depth of how we have those conversations, we use the same tools. However, the language we use might be slightly different in terms of our focus on motor initiations versus the social communication side of things. I hope that answered your question. It was from Nicola. And then there's another comment here from Catherine, thank you. She would like to thank me for articulating so clearly how she would like to work but struggle to name. And I think that's a very common feeling as a therapist, and certainly one that study in 2018 indicated, that therapists really can see the value of this way of working, but like I said, because of the way we're trained or the context that we work in, and also parent expectation. Parents come to our services often expecting us to do most of the work with their child in a session. And again, one of the biggest findings of the Play Connections study that I did was therapists' knowledge, skills and confidence in applying this way of working. So yeah, thank you for that comment, and would like to just say that for me was a real journey, and training and supervision really helped me implement this way of working in my clinical practice. So there's a question from Eric. What is the age population that my study has focused on? And so I'm looking at typically that early intervention age range, so 0 to 6-year-olds. And I guess the younger the better when we're thinking about parent-child interactions and parent-child relationship. So as I went further on in my practice, I guess started working more so with babies and toddlers in this way of working, and became a bit of more of a specialist in that age group. Because if we can get in early enough around what responses a child is expecting from the adults in their lives, that has huge flow-on effects. So if over a number of years a child has the experience of when I give a cue that's not seen or responded to, then we're going to start seeing behaviours that affect the wiring of their brain effectively, because that's then how they expect what they're expecting from people in their lives, and also that's how they learn to respond when they feel frustrated. So if you come in as a clinician with an older child who's had much more wiring around that way of interacting, it can be harder, I guess, as we're getting started. However, still valuable. And clinicians who have done my training and work with older children have said there's been value in kind of going back to this concept of waiting and child-led or child-initiated play as a first step. But it's certainly, from my experience and also in looking at the literature, I'm talking about younger children here. Are there any final questions before we finish up? Okay. So thank you for the interest today, and I always love presenting this way of working. And I would just like to add that when I deliver training, I do cap the number to 30 as a maximum, to make sure that there's lots of opportunities for participation and a real focus on building skills and confidence. So if you would like to attend my training, I would love to see you there, and yeah, look forward to also just hearing from people how they're going with their clinical work and starting to include a relationship focus. We've set up a special interest group at MAMRA, and I'm just going to flick to the last slide so that you can see the how to find that. Okay. So if you'd like to contact me, that's my email address. And at the bottom here is the Facebook group that you're welcome to join as well. Thank you very much. I hope you have a lovely afternoon. See you.